previously. She earned her dental degree from Hacettepe University and her master's and PhD in endodontics from Yeditepe University. She served as a faculty member in Yeditepe University, and she was the PhD program coordinator and vice dean in that university. She completed training in evidence-based dentistry at the University of Oxford and was a visiting faculty member in the University of Toronto. Currently, she is on sabbatical and serves as a faculty member at the Louisiana State University Health Sciences Center School of Dentistry in New Orleans, United States. She is a pioneer of microdentistry in Turkey and authored numerous scientific publications and book chapters, and she serves as the editor of the endodontics section of European Oral Research and is an active member of the ESE and American Association of Endodontists. Okay, the stage is yours. Professor Meriç, you're going to continue with the topic of pain management. So we are at your service and we are all ears to have your informative and nice lecture. Please go ahead.
Thank you very much, Dr. Assadian. Thank you very much again inviting me to give me the honor to your residents and the endodontic colleagues from all over the Iran. So you already made a summary of my CV, and also for the ones who didn't attend before, I would like to mention that I am a good friend of lovely Nekofar family and Dr. Assadian, and I'm an endodontist. Basically, I have some areas of interest that, like every teacher, will like some topics more, right, to talk on. And this is the lovely department that I work in Istanbul, Yeditepe University from Turkey. And this is the department that I currently work at in New Orleans, United States. And today we are going to talk about how to apply cryotherapy, usages of corticosteroids, and when to consider opioids in endodontic pain management. And I would kindly ask you to scan this barcode because this is the only way they put you for me to put there so that we can interact more. Last time we couldn't much because I didn't know that the residents were not allowed to open their microphones and ask the questions. Could you please answer this question for me? Which methods can we use to check the success of anesthesia? Alternatively, if you cannot scan it, you can go to menti.com and enter this code to menti.com and vote in the presentation.
They can scan this QR code and then they can scan the QR code to answer the question?
Yes, please. Alternatively, they can go to Google. Yes, welcome. Somebody is here. Go to menti.com if you cannot scan and enter the code. You're going to go into the presentation. Which one is easier for you? Yes, you can give multiple answers because there are more than one answer for this question.
QR کدش اونجاست. نه میگه اگه QR کد نتونستی.
Yes, code is correct. And also you can use electric pulp test with 2 consecutive tests. Okay. It was from previous presentation. Just I wanted to make a little catch up. And cryotherapy refers to decreasing the tissue temperature for therapeutic purposes. And To improve the success rate of inferior alveolar nerve block, these two studies used just the same methodology. What did they do? They made an inferior alveolar nerve block with lidocaine and applied cold packs on the vestibular surface of the tooth interested for 5 minutes and waited 15 minutes after lidocaine inferior alveolar nerve block. So what happened? The first study had a success, this is the control group with a success rate of 30%, and this is the cryotherapy group with a success rate of 55%. However, in the second study, they achieve only 50%, although their control group have a higher rate. However, these two studies, it is not because the first one from Turkey, the first one has the adult patients and the second one has the pediatric patients. So it seems that cryotherapy is more successful on adult patients. And Penn Group, dear Meriç Karapınar and his friends made a very nice systematic review and meta-analysis on the effects of systematic corticoid uses on enhancing the success rate of local anesthesia. And they concluded that corticosteroid use enhances the success rate of inferior alveolar nerve block. Researchers included 12 studies into their review, and they were focused mainly on 3 administrative ways. I have chosen one representative study from each of them. The first study was from Bidar and his friends, and they compared 400 milligrams of ibuprofen and 4 milligrams of dexamethasone orally 1 hour before. They said that there is no difference. So to me, why to use corticosteroid if it has the same effect with non-steroid anti-inflammatory, which is easier to use. And the second representative study says that dexamethasone gives a higher success rate, improves compared to diclofenac. However, to me, in this study, there is no control group with local anesthesia. I would like to see, because if I will give something PDL, I prefer to give like articaine, lidocaine, something that I am used to and available in my clinic. However, they don't have such control. And the third representative study applied corticosteroids in a buccal injection. They had a control group of articaine, and as I assumed, articaine has a higher success rate to improve success rate of inferior alveolar nerve block compared to dexamethasone and compared to tramadol. Although they concluded that there is no difference between these medications when they are given buccally, articaine seems that more successful. So why to use dexamethasone buccally to improve the inferior alveolar nerve block? To me, it seems it is not very useful. And when I am reading to prepare this presentation, I saw this study which shows that buffering with sodium bicarbonate, which is available here in our clinics in the United States, actually decreased the time of onset of inferior alveolar nerve block, which is a good thing. And it also decreases post-operative pain and also improves the duration of inferior alveolar nerve block. However, it doesn't have any effect on the success rate.
Excuse me, since we do not have this opportunity in our country, can you explain more about how to mix these two drugs together in a confined volume of the cartridge so that you can buffer the local anesthetic solution?
A very good question. Actually, it is coming like a capsule, and you put the cartridges just to connect them. There is a very little amount of solution inside of this capsule, and it's perforates the carpule, the plastic part, and like a bleaching agent, maybe you have the bleaching agents, you connect them and mix them to each other, then put the they mix in the same syringe. It is very convenient to use actually, but it seems as if it is bigger, but it is very small in volume actually. Very easy. They
And
buffer it, but according to research, it doesn't improve the success rate.
However, you use it
improves some other
routinely in the
things.
United States? You use it routinely in the United States?
Residents use it. So far, I haven't used it on my patients, actually, but I saw them there using.
Okay,
I
sorry
think
for
they see some benefits, but this research say that it doesn't improve the success rate, but it improves onset, postoperative pain, and duration.
Sorry for interruption. Thank you. Go ahead, please.
No, my pleasure. So, if the patients who have had previous difficulty with achieving anesthesia may experience more failures, we all know this. Let's say you have a patient that, Doc, I always get difficulty to get numb, and I have a tooth pain. I'm in pain now. So, with irreversible pulpitis, what would you do for this patient? If you make a summary until now, if you have like 60 minutes, you can give an unsteroid anti-inflammatory drug or a paracetamol based on the patient's indications. Or if you have only 30 minutes, you can give ketamine with any type of liquid orally. If you have only 10 minutes, then you can make a buccal injection with tramadol. They all improve the success rate from 30% to 60%. After that, during operation, you can do a go gates. First, we do the go gates because it takes almost 20 minutes to achieve the highest part. Then, in addition to that, we need to make an inferior alveolar nerve block. But why we are doing inferior alveolar nerve block, then we suggest to make it slowly in 1 minute, which is 60 seconds. After doing this slow inferior nerve block, you can apply ice or cold pack on the vestibular surface of the related tooth for 5 minutes. And after that, you can do a buccal injection, preferably with articaine. And following that, you can do a intraligamental injection to the related tooth to achieve a higher success rate. If you have apparatus for intraosseous injection, as we discussed in the previous lecture, then you can also use an intraosseous injection. But after all of doing this, there is a chance of not getting anesthesia, not getting the patient numb to 5 to 10%. Then you should be prepared to be an intrapulpal anesthesia, preferably with a gun type injector, which is easier for your hand, not for the success, but this type of needle is, I think, easier for dentists to use. So you can still vote with the same barcode, or you can go back to the Menti with this code 3738. Is it visible, Dr. Assadian? Is the code visible here? Can you see it? Go to menti.com if you are not inside of the lecture and enter the code 37382017 and please answer the question. How many seconds is better for inferior alveolar nerve injection? Dr. Assadian, can you ask your residents, do I need to show the barcode again? Or can they enter to menti.com?
Sorry, can you spell the name of the site, the address of the site? Menti.com or mentimeter.com?
Menti.com. Same thing,
Menti.
actually. Menti.com. So isn't it visible on top of the slide?
No, unfortunately not, because there is a superimposition over here. I cannot get rid of that.
Oh, okay. You can just, with the cursor, you can move that Zoom panel if you want.
Right.
Have you seen
Now
it
it's
now? 3738 2017.
سیاه 38 20 17.
Yes, 60 seconds.
Okay, each of us should answer personally.
Yes, from your phones. It's okay. Thank you very much for the ones who answered the questions. Yes, it was 60 seconds actually. And bupivacaine is contraindicated for intraosseous injection due to cardiac effects. Yes or no?
The next question.
Thank you very much.
Is it true or false?
Yes. Which technique causes high occlusion? Intraligamental injection or intrapulpal injection? Thank you. Indication for intrapulpal anesthesia is 5 to 10%. Is it true?
Meriç, wait a minute, please. Wait a minute. Some of us are not in yet.
Okay.
Menti.com بزنین اون کدی که گفتن رو بزنین کد یه بار دیگه بگین هر کی تک تک جواب بده با هم مشورت نکنید تک تک جواب بده please just answer personally one by one. Meriç, sorry for interruption.
No problem. It's my pleasure.
شما اوکی بچه تو این دکتر عارفینه شما توی الان اوکی همه تو این همه دستشون خیلی خوب پس اوکی let's move on.
Okay. And cold pack application on the vestibule surface of the tooth for 5 minutes improves the efficacy of inferior alveolar nerve block. Yes, the answer is true, actually. Okay. Okay. Buffering local anesthesia with sodium bicarbonate increases
You should have waited for us to enter our name.
Success or duration? Which one? There is only one answer. Yes, duration. Thank you very much. Postoperative pain management. What is the prevalence of postoperative pain? Why are we talking about this so much? Yes, That's great. True. It has a wide range from 3% to 58%, but it is unavoidable. Why do we have such a big range? Because there are some factors affecting it. And finding all the root canals has a positive effect, but sometimes we cannot find, right? Respecting the working length has a positive impact. However, sometimes we do overfillings, right? Sometimes we do underfillings. So if we do adequate obturation without overfilling, underfilling, it has a positive impact. If we use crown down shaping, it's better. So it decreases postoperative chance for the postoperative pain. And apical extrusion, avoiding apical extrusion, decreasing chance for postoperative pain. And avoiding hyperocclusion is something that we do like a reflex. However, let's see if it does really have an effect on every tooth. It is more effective on the teeth with preoperative pain, with vital pulps, tenderness to percussion, and with no periradicular radiolucency. So we should not rely on that. And when we have a postoperative pain, first we should judge that if we did a good job or the previous dentist did a good job. If the infection has been eradicated, if the root canal filling is good or not. Sometimes it is good, but if the shaping is enough, if the infection is completely eradicated. If it is not, if we think that if we didn't do it ourselves, trust the previous treatment, then the best way is rechecking the working length and shaping, improving the shaping and cleaning if necessary, then put calcium hydroxide and temporize the tooth. So let's talk a little bit about the calcium hydroxide. Does it really work? Does it really work for postoperative pain? What do you think? Yes or no? Oh, class divided into two. I'm so excited. Again, 2 and 2. Okay. Well, yes, it works. Calcium hydroxide is better than no intracanal medication. Then the question is there anything better than calcium hydroxide? Do you think any of these are better than calcium hydroxide? You can give multiple answers. There can be more than one correct answer.
Exactly. In which way better? You mean for the control of the pain or for the
Yes.
outcome? Or just pain?
Just pain, yes. Postoperative pain.
بچه این نتیجه چیزیست که ما داریم تایپ میکنیم داریم میبینیم.
There is a trust in corticosteroids here. Good. Yes. So nobody thinks that chlorhexidine is better than calcium hydroxide and silver nanoparticles. We really don't know much about them. However, they have also been shown that they are better than calcium hydroxide alone. So all of them are correct, actually. They're all better than calcium hydroxide alone. If we think that there is a complete debridement of the infection, then the only thing that we can do is the checking premature contacts, right? So what can we do else? If there is a preoperative pain, then there is a higher chance for postoperative pain. In this case, it has been shown that bupivacaine, which is a long-lasting local anesthetic, we don't have it in Turkey, and before, as far as I remember, you don't have it in Iran as well. However, if you use bupivacaine for inferior alveolar nerve block, then you have a high, it significantly reduces postoperative pain at 6 and 12 hours compared to lidocaine. And also, I think this is a good time to say that postoperative pain is usually a 24 hours thing. Usually, we will talk about the exceptions, but so decreasing the postoperative pain at 6 and 12 hours is something significant. So, for the medications, we use analgesics, corticosteroids, and opioids. Irreversible pulpitis. Why are we so concerned about this disease? Why do we have more postoperative pain compared to the other types of pulpal and periapical diseases? In this phenomenon, we have primary hyperalgesia and secondary hyperalgesia. Primary hyperalgesia means inflammatory mediators reduces the pain threshold of stenoreceptive fibers so that they have an exaggerated response to normal stimuli. And secondary hyperalgesia is prolonged nociceptive input to second-order neurons induces central sensitization. So why do I put paracetamol in addition to opioids here? Because this is a well-cited article, and I had a chance to have a look at it when I am preparing these presentations. It has a more central effect mediated through activation of descending serotogenic pathways. And depending on this, I assume that this is my hypothesis. Please feel free to share your ideas, Dr. Assadian and Dr. Nekofar. The patients with a prolonged pain story, longer pain story, may benefit combinations of paracetamol compared to the ones which has a shorter pain story. And also opioids attach to proteins called opioid receptors on nerve cells in the brain and the other organs. They can effectively relieve the pain. So, to reduce the chance for postoperative pain, a non-steroid anti-inflammatory taken immediately after the treatment decreases postoperative pain. We all know this. If non-steroid anti-inflammatories are contraindicated, we can also use paracetamol for this purpose, although it is less effective than non-steroids. Until now, we were taking precautions to decrease the chance of postoperative pain. However, if the pain starts from this point, if the pain already starts, how will we address it? How will we address it? When the patient starts, the medications given called rescue medication. They are prescribed to address insufficient therapeutic effects and prevent the worsening symptoms. This is a very, very old chart. I have checked the new version of the Cohen's pathways of the pulp. It is not really it is not changed. They all only changed this part, and they now start giving lower doses of paracetamol for mild pain. So it has not been really changed, my understanding is. So if the patient can take non-steroid anti-inflammatories and with the mild pain, we can use with the lower dose. If he cannot take non-steroids, then we can start with paracetamol. For the moderate pain, we can increase their doses. And if we have moderate pain on the paracetamol side, we can add a codeine. On the non-steroid side, we can give a combination of paracetamol and non-steroids. But we have severe pain. I think this is the most important part. Then on the steroid side, we can add an opioid to the combination. On the paracetamol side, we can add an opioid to the paracetamol. If you look at the opioids,
Dr. Meriç, can I interrupt you? Can you kindly
yes.
go back to the previous slide, please, or
Sure.
even this one, because here is fine as well. I'm asking about the oxycodone because here we have actually the equivalent to oxycodone, 10 mg, I believe. So is there any way of calculating it? Because whatever that's available for us that we can prescribe is just codeine. So can you tell us how we can calculate the dosage of codeine equivalent to 10 milligram of oxycodone?
Well, I don't memorize it, but there is a chart. You know, I put it in this presentation, but I removed it somehow. There is a very nice conversion table in the Cohen's Pathways of the Pulp last version, 12th edition. I'm so sorry for removing that. It shows how you can convert hydrocodone, oxycodone, codeine to each other. And I am not familiar with the medication that you told that available for you. I'm not familiar with that, but maybe you can find it in Pathways of the Pulp last version. I'm very sorry.
I think in Iran there is only codeine available.
I don't know. In Turkey, we have tramadol, oxycodone. We have it.
Yeah.
I usually
We do have
prescribe oxycodone. But here in the United States, they have both of them, hydrocodone and oxycodone. And this one, Percocet, is more popular, I believe. And the blue one is usually prescribed. This is my observation. And however, opioids can be highly addictive, and the risk of addiction is especially high when opioids are used to manage chronic pain over a long period of time. However, we may think that, so as we prescribe them only for a few days, it is not a big deal. And if you have really serious post-operative pain, I prescribe them, honestly. However, now they say that even one dose of opioid can be a gateway for a person to develop an addiction. So we have to be responsible for that sense. Here in the United States, opioid addiction is a really big problem. That's why there's advertisings and extra education, trainings, and warnings about this situation. And that's why when I am prescribing, and also opioids may cause dizziness, drowsiness, blurred vision, and such side effects. Here in the United States, pharmacists have pre-prepared etiquettes for opioids. They write it down. But in Turkey, I'm not sure if our pharmacies do it on a regular basis, systematically. And to be on the safe side, both for patient safety and both for the dentist safety, I always put a prescription note that patients should not use, drive, and operate machinery until at least 24 hours after the last dose and after all side effects have resolved, whichever occurs later. I put such a note. I know that this is too precautious because actually 4 to 6 hours their effects are limited to that. But I am not sure because I don't prescribe it very often and I want my patient to be safe. And I write a report to the patient to rest at home, both because of pain, because of the opioid side effects. And also, this is an, I think, interesting thing that in hair, it can be detected, any opioid can be detected for 90 days on the hair of the patient. And the same group, again, for UPenn, made another meta-analysis about systemic effects of systemic corticosteroid use in endodontics for managing post-operative pain. It decreases post-operative pain when used preoperatively or immediately after treatment. This is what the researchers concluded. This time, they included 29 studies. And what is also interesting for me, they say that side effects distributed evenly between experimental and control groups, which means that none of these studies really reported any side effects regarding corticosteroids, which was surprising to me. And also they said that regarding administering ways, oral bay is better than ligamental injection, and it is better than infiltration method, and it is better than intramuscular method in terms of postoperative pain. So rescue medication, in this study, rescue medication was included as well as the preoperative ones, but whereas intracanal application was excluded because they say that this is not a way, this is not a systemic way. That's why I included this study in this presentation. Says that intracanal corticosteroids significantly reduces postoperative pain at 4 to 6 hours. And however, I don't know how you do that. In Turkey, we do still root canal treatments. I don't know, maybe not majority of them, but a significant number of them in 2 sessions, especially if there is symptomatic apical periodontitis. However, here in the United States, at least in the department that I work now, they almost never do that if they don't have a acute apical abscess draining. They always do 1 visit. So they don't apply calcium hydroxide, and they don't have so much pain, surprisingly, actually, but significantly reduces this and this is Jun Ko, one of our very nice, gentle residents. Now I'm going to talk about the case of him. This patient is a 34-year-old female. ASA1, completely healthy. Where do I put this? Okay, and 4-6, this is 4-6 for you, right? Right mandibular first molar. Your numbering is 4-6 in Iran too, right? Dr. Assadian?
Yes, we do the same.
You call it 4-6, right? Because in the United States,
Yes.
it's different.
They have universal numbering, probably, yes? They have the universal numbering from 1 to 32.
Yes. But in Turkey, we call this to 36 as well. It is more it is an exaggerated response and lingering pain to cold. So irreversible, symptomatic irreversible pulpitis was diagnosed. When the patient is referred to the postgraduate clinic, they always take a preoperative CBCT here. That is why this tooth has a CBCT. And nothing unusual. This is just a regular mandibular first molar. What's happening? June treated it in 1 session, of course, and it is a little bit overfilled here from this angle, and patient reported no pain the day after because they always call their patients to learn if there's any pain or not. And however, it starts here. On the day 2, pain came back. On the day 5, June re-evaluated and found that 44, 45, 46, 47 were percussion sensitive, and 46 was the worst. occlusion adjusted, and medrol dose pack, which is an intraoral corticosteroid, for 6 days was prescribed. So on the day 9, she started feeling better. However, when the cortisone was finished, corticosteroid was finished, which was day 11, just the next day, the patient started to feel some sensitivity when eating anything hard. 1 week later, pain on eating anything hard and soft, so it was worsening. On day 20, amoxicillin and ibuprofen was given by her physician for flu. And the patient come back, another radiograph, another CBCT taken. This is post-operative to understand if June missed any root canals, anything else is missing, any voids. However, nothing such things were detected. And so we suggested to put intracanal steroid. So on the day 36, catapercha filling was removed. Calcium hydroxide and steroid was placed. However, they don't have leather mix in United States. Eventually, they don't have something that we don't have, and that because of that, one of our faculty has an ophthalmic version of steroid. We mixed calcium hydroxide and this ophthalmic version of corticosteroid, which was a prednisolone, and put it into the canal to apply intracanal corticosteroid. On day 64, patient reported no pain, like 1 month later, with calcium hydroxide. She reported no pain when she came back to finish the treatment. This time, June was very careful not to make any overfilling, and it is completed. And 1 week later, patient reported no pain. And she wrote June that I really appreciate the patience you have had me throughout this process of that frustrating tooth. She was really grateful. But now I'm thinking that what we could have done, we could apply corticosteroid in a PDL way, intraligamental way, or intraosseous way, and we may not need to remove the root canal treatment because it was already a good root canal treatment. But we didn't have, for the intraligamental injection, we don't have any dental cartridges full of corticosteroids. Do you have?
No.
No, yeah, we have a problem. And that's why we read this. I think the authors are from Iran, right?
Yes.
We wanted to mimic their way to do that. However, the authors say that they describe how they did lidocaine group and say that they did the corticosteroid in the same way, but we don't have any cartridges in corticosteroid. Now we are planning, probably they did this, they emptied the lidocaine cartridge and take the corticosteroid inside, maybe an intramuscular one. This is what we are planning.
Or probably they have filled the empty cartridge with the solution, but we do not have this pre-prepared system for this in Iran, pre-filled system.
Yes,
So
yes. Same in United States, same in Turkey, but I mean, sometimes, when we submit the papers and they editors want us, they say that, okay, this is a very nice paper, but you should give more details about your methodology, and it takes a lot of time, and I feel sometimes angry. But now I understand that it is for the sake of reproducibility. If the authors told explicitly what they did, so our lives would be easier. Now I am thinking in this way. And application of cold covered with water for vital pulp therapy on the exposed pulp in the first paper, they put sterile ice onto the pulp for 1 minute, and in the second study, the pulp was irrigated with cold saline 2.5 Celsius for 5 minutes, and they both said that post-operative pain was less than the control group.
Sorry, Professor Meriç, there's a question.
I have a question about the previous case that you shared with us. Because usually when we have preoperative pain, and the preoperative pain controlled by the root canal treatment, and a day, because you said that a day just after the treatment, there was no pain. Am I right?
Yes, true.
Okay, so in that situation, if we have some sort of after 2 days or delayed pain, something like that, I always suspicious about the initiation of some sort of infection. And therefore, I prefer actually, if I want to prescribe corticosteroid, I prefer to do that at the same time with the prescription of antibiotic to make sure, because I believe just prescribing corticosteroid may make the patient susceptible to a spread of the infection as well inside his body. So we may end up to some sort of bacteremia, septicemia, something like that in a severe situation, because we control the way of the patient's response by prescribing corticosteroid. What do you think about it?
Well, actually, I agree, but here their treatment protocols are a little bit different. For the irreversible pulpitis, as soon as they do the root canal shaping, they think that, if it is adequately done, they think that infection has eradicated. Even though for the symptomatic apical periodontitis, they have a tendency to behave like this. But actually, the primary supervisor at that shift was not me, and they chose to prescribe Medrol dose pack. And then antibiotics was prescribed by the physician for the flu. But at the end of the day, this is a very interesting case to me. At the end of the day, intracanal corticosteroids stop. And now, June, the same resident, as a bad luck of him, he has a more interesting case. This is a two-rooted premolar with a complicated anatomy and a big lesion. He treated it very well, and the lesion healed. Almost healed. 3 months later, we have a post-op radiograph, not totally because it was a big one. However, patient developed the pain, and now, as the root canal was complicated, anatomy was complicated, and the lesion is healing, we don't think that this is infection. Again, we expect something inflammation, and that's why we are getting prepared to do an intraosseous or intraligamental corticosteroid. Actually, we are getting prepared for that patient. But theoretically, I agree with you. But for irreversible for the pulpitis confined within the root canal, our head of the department here does not in the favor of prescribing antibiotics.
Yeah, I'm not saying prescribe antibiotic in the first as a first action. I'm talking about when I decide to prescribe corticosteroid, I should be aware about the consequences of this prescription. That is the issue that I'm a bit worried and I'm concerned about.
Yes, I agree with you.
By antibiotic, even some antibiotic like metronidazole to cover also the anaerobic bacteria as well as other bacteria is important. So a broad spectrum antibiotic like amoxicillin is good, but not enough for this situation, especially after obturating of the root canal system. In addition, sometimes I'm not sure about the quality of the isolation during the root canal preparation, and I may push some bacteria outside the root canal. If immediately after the treatment I have pain, my interpretation from that is, okay, I have actually some sort of maybe over preparation or something like that. So it's not infection because it happens just after my treatment. But if it happens after, for example, 2 days and there is no pain, so there's a window of 2 days without any problem, and then after that, I've seen actually patients complain about the pain. Then I'm worried about infection more than anything else, and it's not just inflammation. Inflammation can be done just after the treatment as a post-operative inflammation. So I don't prescribe antibiotic immediately, definitely. But I wait for the response, just analgesic. So that's the issue. So that's the only thing. So that window of the painless post-operative situation in comparison to 2 days delayed initiation of the pain.
And one more thing that I would like to add to Professor Nakufar's comment is that as you may see in the CBCT of that case, you will see a complex anatomy of the distal root canal. So I think that probably in the first treatment attempt, this complete eradication of microorganisms from the root canal system has not occurred successfully. So therefore, in a second attempt, probably a better eradication of bacteria took place and resulted in success. What's your idea?
Complex anatomy, you mean like on the distal?
Yes. If you go back to the second CBCT, you will see that there is a kind of fin in the distal canal located in the lingual side, which shows that there is probably a kind of ramification in the distal canal. See here. Yeah.
Here?
Yes. And there is also a gap between the filling material and the root canal wall. Yes, in this cut.
Yeah, actually on the axial, I'm not sure because it is sometimes because of the cross section of it's taken. This is a video of the
In the axial
CBCT.
also, we do have this, In the axial aspect, also we have the tendency of the root filling toward the buccal side more, and there is a void in the lingual side. And I think that the root canal preparation and eradication of bacteria probably in the distal root has not been completed enough.
Yeah, maybe. Yes, you may have a point. Yeah.
Yes.
Anyhow, the patient is happy.
Yeah, patient is happy, yeah. And intracanal cryotherapy, a final intracanal rinse, there is enough evidence to show that a final intracanal rinse with 2.5 Celsius saline for 5 minutes reduces post-operative pain at 6 and 24 hours, which is easy. So the chance for post-operative pain is lower in case of preoperative pain. This is so simple. I will pass this. So this is so simple for the residents. So which one works to decrease the chance for post-operative pain? You can give multiple answers. Do I need to show the code again? Okay, thank you very much. True, yes, all of them are true, correct. And does systemic corticosteroid use decrease post-operative pain? Thank you. And which ones of the below taken immediately after the treatment decreases postoperative pain? Yes, all of them were true. Thank you. And which intracanal medicaments work better than calcium hydroxide? Yes, every one of them, including silver nanoparticles and chlorhexidine, every one of them. Yes. Thank you very much for writing them down. A final rinse with 2.5 Celsius cold saline for 5 minutes reduces postoperative pain following root canal treatment. Thank you. Please look at your devices.
Meriç, I want to say a big thanks for this very, very advanced technique of teaching. And I believe our residents are really very lucky to have you today. Thank you very much indeed. First, I want to thank Hadi for arranging this meeting with you. And then a big thanks to you because you spent a lot of time preparing this lecture and this quiz for us. This is amazing. I learned a lot. Thank you.
Thank you very much for your nice words. Okay, then this is almost the end of our presentation, and I forgot to tell you about the alligators. Actually, this picture has been taken by my husband in front of the river in our apartment complex where we live. And this is my son watching the alligators in the lake. But in Louisiana, they are very common and they live it friendly. Actually, they hunt them and eat them.
Oh my God.
Yeah. This is a traditional dish for them because they have so many of them.
I thought in China, Chinese people ate a lot of different things.
Different living. Yeah. In Louisiana, in the previous lecture, I already showed the residents and Dr. Assadian that they really eat different seafood than our cultures. Hope we meet again and I show you the pictures in person. So if we make a summary, we took a comprehensive pain dentistry history in the first lecture. We talked about how to enhance the success rate of inferior alveolar nerve block in the first lecture, and talked about managing postoperative pain. And we talked about how to use corticosteroids, and we talked about when to consider opioids in endodontic pain control. And this gentleman here giving me a ring, actually married to this pretty lady. But this ring is very important because it is the championship ring of the Saints football team.
Oh.
Yes, and this cup that everybody wants to touch, and this ring, everybody wants to have a picture with it. And because this gentleman standing behind me, yes, true, he's standing now, is one of the owners of the Saint football team of the city. And this is a cheerful moment that we enjoy these items. And if you would like to visit us and to see these parades and collect these beads, the best time to come is February, actually. But if you're more interested in music, then I suggest you to come to visit us in April. And of course, you can use my emails to ask questions and contact me for whatever you would like to.
Thank you very much. Thank you. Thank you very much.
Okay. And this is the end of my questions. Are welcome.
Thank you very much for your kind, nice, and informative lecture. I really learned a lot, and I'm sure that everybody present in this session learned a lot from this session. It was really amazing the way you taught, the way you presented, the way you asked questions. It was really impressive for me as a very novice student in your school, actually. I'm really proud to be your colleague and to be connected with you. This was a very interesting opportunity for all of us to attend this nice and informative session. And I hope that this continues forward and forward and forward. If time permits and if your schedule permits. And it's really a great pride and a really good and prestigious point in our career. Thank you very much, Professor Meriç. I hope you're doing all fine with you and your family and your colleagues in Louisiana and the United States. And I hope that in case you come back, you pay a visit to Tehran and we stay together and we meet face to face and in person to attend conferences held in Iran and also to have mutual sessions in our university. Thank you very much. Have a good time. I don't know if that's at all possible to have a common photo. It's the professor is
If you want to take a photo, we should go on that side together.
So let's see.
Yes, of course. But how can we do this?
I don't know.
از شعرش باید بیاری بیرون.
چجوری میتونم همون میخوام همین کارو کنم. سلفیو که اکسیت هایت
نه بالا نه.
It's also my pleasure and honor. And thank you very much for Dr. Nekofer and you for organizing this. I'm looking forward to future collaborations with you.
No, but yes, you should be in the center of the camera.
You're not in the center of the camera.
Sharing number bad.
Is there anything that I can do to be in the center?
See?
Look like Sibyl John without your glasses. Hi, Professor Meriç.
Hi.
Professor Saraf, the head of postgraduate program, is having a point to you.
Hi, Professor
I'm
Meriç.
honored.
Have you
Hi.
here? Thank
Nice
you
to
for
meet you.
invitation. And I told Dr. Nekofer that you look like Sibyl John without glasses.
Thank you.
Nice to have you here. We are looking forward to have more sessions with you.
I'm
Thank
looking
you so
forward to. It's my honor, pleasure to be with you.
Thank you so much.
Okay, thank you very much and see you soon.
See you soon.
Any comment, anything you want to add? Any question from Professor Meriç, from the residents? Okay, take care. We will be in touch.
Take care.
Bye bye.
Bye bye.
برن اسم یه کوچولو با یه کوچولو 2 دقیقه حرف بزنم